Hi, I'm Molly Candon. I'm an assistant professor of psychiatry and healthcare management, and today we're going to talk about our team's efforts to build an integrated data infrastructure to reduce suicides in Philadelphia Medicaid. What we're trying to do, which is unique to other studies, is to get a better understanding of where people are in the time leading up to their suicide death. One thing we know from the literature is that most people who die by suicide are not currently engaged in mental health or substance use treatment, which makes it very difficult to prevent. So we were able to access information about emergency shelter stays, about incarceration episodes, about involuntary commitments, and this gives us more opportunity to identify places where we could intervene and roll out suicide prevention efforts. We are not the first to put together data to try to predict suicide deaths. What I think is very unique about this study is our ability to translate our findings into meaningful practices and policies. And we can do that by collaborating with the Department of Behavioral Health and Intellectual Disability Services here in Philadelphia. Once we were able to crunch the numbers, we could go back and present all of our findings to relevant stakeholders. And we're currently in the process of building a curriculum that could be rolled out in non-clinical settings that emphasizes mental health literacy, suicide prevention efforts, and we wouldn't be able to do this if there wasn't this coordinated effort. So I think that's what makes this study unique. Administrative data tends to be collected in silos. It can be very hard to merge these different sources of data. Philadelphia has a pretty unique behavioral health system in that we're able to combine Medicaid claims and jail admissions and emergency shelter stays. So it was the effort of data architects, I think the chief information officer at the Department of Behavioral Health, that even allowed us to look at these sorts of relationships. And it ended up being very powerful, the ability to combine these data, because we found, for example, that incarceration is an enormous risk factor for suicide, that more people died in the month after they got out of jail than in the month after they got out of a psychiatric hospital, at least in Philadelphia Medicaid. I think when it comes to suicide, Medicaid is a very interesting area to study. First off, there are risk factors that people with Medicaid face for suicide, things like financial insecurity, housing insecurity. But secondly, there are opportunities in the Medicaid population to intervene in ways that we haven't before. States are expanding Medicaid, and with that, there is an increase in the number of people who could die by suicide. But we've also found that Medicaid is a protective factor for suicide. If you are insured, you are able to access mental health and substance use services that you can't access when you're not insured. In Philadelphia and in many places, we're seeing an increase in the number of suicide deaths. And in Philadelphia Medicaid, we have seen the numbers climb. However, some of that is due to expanding eligibility. So more people with Medicaid means more people who may be at risk for suicide. We did see some troubling trends in some groups. We've seen nationally higher rates of suicide among white people, especially white men. Here in Philly, we're seeing higher rates of suicide among Black youth, which has prompted recognition from the Congressional Black Caucus. So this is not a new finding, but something we're really concerned about. It's hard to roll out suicide prevention efforts anywhere. I think even in clinical settings, there is time and attention that is needed in order to screen, and then more time and attention is needed to hand someone off to the services that would help. One thing we're very excited about is the possibility of leveraging peer specialists to lead these efforts. These are people with shared lived experience. They've gone through it and they've come back, and they can walk someone through to the other side in a much more effective way than someone like I could. So our goal is over the next year to develop this curriculum and to test it out with different people to see what works and what doesn't and what else we should know. It's really exciting to think about the possibilities that could come out of this work. And I know other cities and counties and states are thinking about how to use their data as well. But at the end of the day, most risk algorithms that predict suicide aren't that effective at preventing suicide. So we need to be feeding in better and more relevant data to those risk algorithms so that we can do a better job of identifying the places to intervene.